Welcome, everybody. My name is Michel Perrault. First, I'd like to thank the organizers for letting us present some of the initiatives that are happening in Quebec. I know that when we look at the media, most of the media in Canada, they speak about the situation in BC, in Alberta, and in Ontario. But in Quebec, it's still a major problem. And I was glad to be able to invite people from Quebec to give you some information on the initiatives that are going on here. And of course, we cannot pretend we will cover everything, but still, I think it will give you an idea of original and I would say very interesting initiatives that are there. My name is Michel Perrault. I'm at McGill University, and I'm glad also that McGill is one of the is involved in also in the financing of this event. I've been involved for 25 years, in programs on opioids, and in Montreal, many projects like the first low threshold methadone program in 1999, the NAOMI, the National Opioid Initiative, where Vancouver was involved in Montreal. That's 20 years ago. The other initiatives like Peers, that in 1999, I remember we started to work on Peers. That was with David March in Ontario, and the methadone, and a program where Guillaume is involved. Anyway, everything to say that we have a good track record on doing original things in Quebec. It's still there, and we have maybe the chance, or maybe it's because we're doing things in a correct way. We're not facing the same high prevalence rate that other provinces are facing now. First, I'd like to, I've decided to invite colleagues that are working, that I know from either research, prevention programs, or academic activities. And that's why it's a highly biased selection of presenters that you'll have. And frankly, in my subjective and personal opinion, I think they're the best in their area, and that's why I've selected them. And also because I know them, it was easy to convince them at the last minute. So the program is very simple. We all have, they will have 10 minutes each to present. I'll warn them after 8 minutes. They're from different perspectives. Francois is at the CCSA. We heard about the CCSA this morning in one presentation. He's been working at the Institut National de Santé Publique for many years. He has I would say, a wider view of what has happened with opioids and overdoses at the Quebec level. And you'll be followed by Guillaume, who's involved with the community level. He's an entrepreneur working, expanding the prevention program, and he succeeded to start from Montreal and be expanded that in all health regions of Quebec. And he will talk about his view. So he has a good understanding of what's happening in Quebec at the community level. Léonie Archambault has research experience, and she's been involved also for I think 12 years in research. And I would say even in Quebec, we've developed the IOT, the opioid agonist treatment injection program, and she's been involved in in coordinating the guide that has been produced a few years ago. I think the best thing is, And that Dr. Cross, that's what he said this morning. You know, we have to share different perspective. It's a complex problem. We have to share different perspective. And Timo has the experience perspective, and I think it's good that he comes in last so he can sort of conclude, and then we will take questions. We have I'll try to collect all the questions. I don't know how much time we'll have, but the best thing is to begin now with the presenters. And so I'll let Francois begin. Francois, I'll stop. Oh, I forgot. Just a minute. I need the slide. I have to talk about the land acknowledgement. McGill University is on a land which has long served as a site of meeting and exchange among Indigenous people, including the Haudenosaunee and the Anishinaabe nations. We acknowledge and thank the diverse Indigenous people whose presence marks in this territory in which people of the world now gather. So I wanted to say that. So now I think, Francois, you can share your screen. I'll just leave this.
Yes, thank you, Michel. Does everybody see my my slides? Yes, good. Okay, so Michel, thank you, Michel, for the very nice introduction. There are other people that might have talked as well as I did, as I will, I hope, on the same subject. My talk will be really informed much by my passage to the ISPQ. I was there for the last 17 years. I just transferred to CCSA. So the best way, Michel gave me this simple task of, creating a picture of the world picture of Quebec, so in 10 minutes. And so I've got the best way I found is to go a bit through the history of the public health response to the overdose crisis. And so here we go. It's going to be going fast. Before we get into the history of it, though, just the point of departure prior to getting into the history, though, then is looking maybe at putting the overdoses in perspective across the country. As you can see here, the number of overdoses in Quebec is really reduced. And even if you think of the rate, in terms of rate, it's more similar to Atlantic provinces than either Ontario or the Western provinces. Note that on this slide, the data stops in September. So the real number of overdoses for 2023 is a bit over that. It's like 520, I guess, around this for Quebec, but it's overall bigger also elsewhere. So that's the first point of departure. Really, our overdoses came on the radar of public health in Quebec is really to work on infectious diseases, and it was the infectious disease team that worked on safe injection services in Quebec and asked me to be part of this. So I worked on this public health advisory, and one of the things we noticed that these sites or these services were meant also to combat overdoses, not only infectious diseases, but we had no data. We were looking for data to evaluate the pertinence of these sites in Quebec, but we could not find any data. So I ended up emailing our coroner's office, and he sent me back a big Excel file with no names, obviously, but lots of deceased people and toxicology tests, identifying all kinds of substances, but it was not possible to say people had died from overdoses at that point. So a few years after, people at the Institute starting to delve into that question, and they try to understand if things had moved. So on the higher left here, you see that for man, the picture.
We're not seeing your slides move. I'm sorry. Sorry to interrupt. We still have the title paged.
Oh yeah. I'm sorry. I'll...
You have to start.
Yeah, stop sharing once and try one more time. So sorry about that.
It says my sharing is on pause.
Are you able to?
I'm going to try to share it again.
Yeah.
Is that good?
Yes.
Okay.
Thank you very much.
Oh, that's good.
Thanks, Leonie, for saving me. Bottom upper left, you see men. So on the right, you see women data. And you see that the trend from 1990, I'm sorry, it's not so clear, but the beginning of the trend is 1990. And it goes down to 2002, 2003, and goes back up again. If we prolong it, it will go up to 2023, I guess. And the rates would go up. This first wave was centered on opioids. I'm going to show later that we worked on other substances at the Institute after that. It still is not moving. Okay, so second slide that I wanted to show, my colleagues tried to differentiate between prescription opioids and heroin, which was the street drug at the time. And it really shows that what was at play there at this initial stage was really the prescription opioids. This is the top line. It's the same thing for women. And you see this is really flat for heroin or street opioid. And so, yes, if I did a more complete picture, you could also see differences in, of course, socioeconomic gradient or even geographical differences, but I don't have time to do it now. So after this picture that was made by my colleague, I was fortunate enough to be funded by the Ministry of Health and Social Services to do work on, what were at that point very either non-existent interventions in Quebec or very low scale, like a few pilot projects here and there. But so I worked doing literature review on community naloxone programs, supervised consumption services. I had done work on injection services, but now the inhalation part came into play and evaluation had come around inhalation. We also did work on drug checking, especially in festive environments, but also I noted at the end of the report that it could be used elsewhere than in festive environments. Also a preoccupation, long-term preoccupation in public health is the criminalization of people who use drug, and so we were looking for alternatives to these, and the Portuguese Decision Commission had been studied quite a bit. And also low threshold dosing has been included in that picture, but at that point it was not tied, or the objective of these services was never made explicitly towards overdoses. But conceptually, I think you get the point that the dosing and overdoses are really intertwined. And so what unfolded next, also at the same time, we were having discussions in Quebec about having a national or provincial strategy around overdoses. And at the same time, so my work that I just presented was in that time frame. And also there were discussions around setting up more monitoring, and colleagues were funded at the NSPQ were funded to do more monitoring, and so it gave us something like this. So in 2017, you see each line is a year and it's by month, but you see the overall trend since 2017 is pretty stable in terms of deaths. It's around, like, I would say between 30 and 45, it was like this. If you see the last year, the end of the year was a bit in the higher range. So there's not a real tendency to go higher than since 2017. Overall, it's not very clear, but it seems to be maybe climbing up a bit in the last months of the 2003 year. Also, monitoring was expanded also to emergency and hospital admissions. We have this is on the INSPQ website. You can also find data on poison central calls for overdoses. And also you will find, we can find an naloxone distribution because there's a community program that's accessible to all Quebecers that can walk in pharmacies. So there's a tracking of how much kits are distributed every year or every month. I'm not too sure anymore. At the same time, also, some colleagues of mine, doctors, tried.
François, il te reste 2 minutes, François.
Parfait. They develop training for different things, pain management and opioid prescriptions among doctors, health professionals for OAT and stigmatization, and also training the public at large for naloxone administration. There are specialized programs like are going to be talked about by colleagues later, but for the larger public, you can find a training on the NSPQ website. There's also, as in other provinces, a urine analysis project, and actually it's involved, it's collaboration with CCSA also, and there are multiple sites across the country that do this type of analysis. So there's detection of drugs in urine, so it can be used in harm reduction, notably. We came back with a different report that's on the website, but also a paper that's in English. So that's why I put the report there. So around the police-led diversion measures, it's been published in the International Journal of Drug Policy. We came back on the Commission of Decisions in Portugal, but I also included the law enforcement assisted diversion programs in the US, known as LEAD. It's almost a trademark as of now, but again, this idea was to look for alternatives to criminalization. Just in conclusion, I don't have slide for conclusion. So in terms of public health profile, I think if you think of BC and talking to people from UBC, hopefully, I think the profile of intervention is maybe the same qualitatively. So the explanation as to why overdoses might be a little less intense in Quebec or other than that, it might be that the drug profile is less risky. For example, there's less opioid, and within the opioid class, even fentanyl is lower. I think Guillaume was saying to me that we found in the bodies of deceased people like 23% of fentanyl. It's very far from the 80 or 90% that you find in BC. Maybe also the one last thing I will note is maybe that the larger social net in Quebec might be a bit more developed. Like there's less inequality. It's increasing especially for a small portion of the population, but it's increasing, but still maybe less than in other provinces. I'm going to stop there.
Okay, thank you, François. Guillaume is our next presenter. So if you can share your screen. Guillaume is that's quick. Okay, so Guillaume is coordinator of this prevention training program. Guillaume, I don't think I have to say too much. Will you introduce what you're doing, Guillaume? Guillaume, we cannot hear you.
Yeah, it's a classic. I just saw it when I was talking.
Okay, good.
It said to me that I have to unlock the mute button. So I was saying that, I'm going to be quick on the ProFam 2.0 program, but basically ProFam 2.0 program, it's a program that gives training in overdose prevention all over the province of Quebec for the community sector, their user and loved one. And the particularity of the program is that the training. It's a one-day training, and it's co-facilitated by a person with living experience of drugs use, and a person with frontline experience or clinical experience of in harm reduction. Actually, my presentation is going to be more about a quick overview of what the community, in a community setting and in community-based organization, what is put in place to fight the crisis we are facing. Yes, we have less death by overdose, but we're still in a crisis in Quebec, and we have a lot of overdose, and it's increasing. So the data is indicating that we are in a phase of increasing. It's not increasing very fast, but it does increase. So I'm Guillaume Tremblay. I'm a person with a lived experience of drug use for many years, and I'm the coordinator of the ProFam 2.0 program. So my presentation is going to be, I'm going to try to, yeah. So my next slide is about action drive it. I want to start with that to talk about what is being put in place by peers, because for me and my understanding of what's going on in Quebec in terms of community action is that peers have a big role, play a larger role in different perspectives. First of all, they did raising the awareness that we had to move on in the Quebec province because the death rate was low. There was not a lot of mobilization to put in place some action in overdose prevention. So they did that at the beginning, especially in 2014. Tools and for further, they put on some different tools and training for health prevention. And actually, it's when ProFam did emerge, did start, and it did start by and for peers. Now it's being expanded and migrated to a larger format. But at the beginning, it was very by and for program. We did put in place rapidly support group and workshop to inform our population that the risk associated to substance use and the switch that was operating in Quebec, in the Quebec setting, about the substance available on the streets and also in the prescribed market, because the prescribed market is increasing as well. Research and knowledge transfer, we did do a lot of advocacy and actually initiated some with research team, some research about the overdose situation in Quebec to understand the situation. And we're still doing that right now. And we are participating when I say we, it's Drug User Association that participating in the translation of those knowledge. Further on, in a community setting, there's the frontline workers. And in the frontline workers, you have peers as well, but you have also different people with different background in terms of academic background, but also work background. But in the community organization, there's good ties between community organization in Quebec to try to implement in the same time together some structural action to fight the overdose crisis we are facing. Actually, we have now different supervised consumption services that have been implemented with the help of the public authorities, but it's the community organization that runs it. Mostly drug checking, same things. We have now different drug checking initiatives that are driven by community organization all over the Quebec province. We see more and more drug checking services are being implanted in different regions of the Quebec province. Community service that are adjusted to the need of the people who use drugs, because as I said, it switched very fast. So now, because it's changing so fast, we have to have consistency in adapting and adjusting our services to the needs of the people. We do participate at the same time of monitoring and data collection that the public health authorities cannot have grasp on it, like some first-hand information when you are on the field. And we do prioritizing some low threshold approach as well, so outreach approach and those type of approach. And the frontline workers are really involved in updating workshop trainings and prevention tools to what they see on the fields. And so they are, with peers and frontline together, are a very good combination to understand the reality of drug user and the reality of the overdose situation in just in time. So we can adjust just in time to because it's moving very fast, and I think you know it. So it's why also Profan has the same approach, trying to get the view from the frontline workers and the view from the peers as well. And now we do all this, but we still have some challenge to face, especially we need some new action to be effective in our intervention, such as safer supply. That's difficult right now, but we still advocating for that. Emphasizing the determinant of health. We think that we really have to have a better understanding which are the determinants of health that are in case in overdose situation, so we can act on it. And enhancing access to integrated services, that's something that we're not there yet with the integration of services in our services in Quebec. And the low threshold is still there. There's work to do on that part as well. Establishing community of practice and action networks. We don't have those kind of networks all over the province. We just come back from BC and we see networks in your province that we can maybe, it's very, for us, we think we should go on that way and a little bit more. Also advocating for peers input and engagement, especially to avoid tokenism of them. Mobilizing both our public and elected authorities, so we can act at different levels. That's something that is lacking a little bit in Quebec right now, and also ensuring ongoing evaluation with research team. Research team has a big role to do to help us facing this overdose crisis that is increasing. I want to emphasize on the word increasing right now in Quebec. Thank you.
Merci beaucoup, Guillaume. C'est très éclairant. Merci d'avoir fait le tour. Thanks for having covered so many initiatives. And so next guest is Leonie. Leonie has quite, in fact, she got her PhD a few months ago. She's a new member of this group, selected group. Leonie has been working for at least 12 years in the area, and she's been involved in many projects, like I mentioned earlier. So she'll try to cover, many initiatives through her view of prevention.
Thank you, Michel. Thank you for this introduction. So I'm having a little bit of trouble with my slides, but I'll do. Just gonna. Okay, here we go. think that's better. I'm going to dive right in. So you will notice on my first slide that I've had a little bit of trouble putting up there, that when we talk about the opioid crisis, I like to think about prevention strategy in terms of the initiatives to avoid deaths, the initiatives to avoid overdoses, and the initiatives to avoid the development of opioid use disorder. And my colleagues did a great job at describing some of Quebec's initiatives that fall into these three categories. But I would like to add a few words on opioid agonist treatment in Quebec, because pharmacological options have significantly expanded during the past few years. For instance, opioid agonist treatment are more accessible than they used to be in the primary care, thanks to buprenorphine, and also to the fact that the exemptions are no longer required for practitioners to prescribe methadone. But more recently, the recognition of slow-release oral morphine as a treatment option in Quebec has also provided an extra tool to prescribers. Unfortunately, unlike BC and Ontario, Quebec treatment settings have not been successful in implementing a sustainable injectable opioid agonist treatment program so far. And although our provincial government funded a feasibility study and also funded, as Michel was saying earlier, the writing and publication of provincial guidelines to implement injectable opioid agonist treatment in 2020, it has not been sustainably and successfully implemented so far. However, safer supply practices have been more widely adopted since the COVID pandemic, to the extent where our Provincial College of Physicians has published a statement to guide this new practice, and our health ministry also supports its deployment through the provincial overdose prevention strategy. So back to this three-level framework of prevention that you see on the screen. So it tackles risk factors at different moments in the trajectory of substance use. But the issue of social inequalities is cross-cutting. For instance, socioeconomic marginalization, mental health issues, physical health issues, chronic pain, incarceration, homelessness. These are cross-cutting risk factors for all three levels of negative outcomes related to opioids that you see on the screen. That being said, since you are interested in hearing more about what's going on in Quebec, I want to bring your attention to some of the recent work that we have conducted in Montreal, that I've been conducting actually as part of my PhD under the direction of Michel. This is why he so kindly invited me, because he's my former director. So this work we have published in 2023, so you'll be able to access it if you are interested in knowing more. So what we did is we collected data from just under 300 patient files from a large Montreal opioid use disorder treatment center. And the idea was to gain a better understanding of the distinct profiles of people with opioid use disorders in Montreal. And our statistical analysis, which was actually a latent class analysis, led us to identify three main profiles. So one of these profiles, as you can see here on the slide, is characterized by very precarious living conditions, such as higher probability of homelessness, severe comorbidities, more polysubstance use, injection, and as you can see in the column at the right, a 67% chance of reporting an overdose event. The second profile is characterized by more stability, such as a higher probability of being employed and a lower probability of presenting many biopsychosocial comorbidities. This profile is also characterized by a higher probability of using specifically heroin and alcohol. And as you can see in the column at the right again, this profile has a 33% chance of reporting an overdose event. And the third and last profiles just below is characterized by a higher probability for chronic pain, older age, oral administration of medication type opioids, cannabis use, and a lower probability for overdoses. As you can see in the column at the right, this profile has a 27% chance of reporting an overdose event. And I wanted to tell you about this work because I find that this type of information is important to guide prevention strategies. Again, it highlights how social inequalities and social determinants of health play a role in the magnitude of the overdose crisis for some specific populations. In fact, the qualitative component of our research underlines how many people start using opioids to manage physical and psychological pain issues that are often rooted in poverty, trauma, and lack of opportunities. Another thing that we've highlighted while analyzing qualitative data from this research is that people, through their opioid use trajectories, well, they can move between profiles. Obviously, we're always hoping for people to move towards safer profiles and not the other way around. And this supports the importance of not only treating the opioid use disorder, but also really supporting people's various biopsychosocial needs in terms of physical health, mental health, socioeconomic conditions, and socioeconomic opportunities as well. So to give you an example of how, or a few examples of how we address these biopsychosocial needs in Montreal, my colleagues talked about a lot of initiatives, but there are two other initiatives that I'd like to share about. So you'll see that this slide contains examples of original community resources and programs that you can find in Montreal with regards to offering services to people with opioid use disorder. But the first one, it's called Metadame. I think Timon will tell you a little bit more about it in a few minutes, but I like that it's original in the sense that it is a community organization that was created more than 20 years ago for people with an opioid use disorder by people with an experience of opioid use disorder. It is still mostly run by peers. And it now provides 43 affordable apartments and a bunch of other supportive services to people who are experiencing either homelessness or residential instability. And the services are based on a harm reduction approach that doesn't require abstinence. And I want to circle back to the profiles that I just told you about, just to highlight how this resource provides means to improve people's global health and socioeconomic conditions, thus supporting a transition, hopefully, towards more stable and safer profiles of opioid use. I also want to draw your attention, I might have time just to tell you a little bit about another community-based organization called Le Giffard, which provides 7 supervised apartments for families where parents receive treatment for an opioid use disorder. Again, this resource provides means to improve families' global health and socioeconomic conditions, but it also supports parenting skills. And what's original about this resource is that it's based on a harm reduction philosophy, which means that as long as children are safe and as long as there is no disturbance in the building, substance use is not a reason for eviction. It's not a reason for disqualification from the program, which I find to be very groundbreaking in the field of substance use and parenthood. So I want to leave room for my colleague Timon, who has really interesting stuff to share. So I will leave it at that. Maybe just to tell you that my next slides contains examples of a number of Quebec programs that support knowledge transfer and training for professionals who work in the field. The slides will probably be available online, I believe, so you'll be able to look at these Quebec initiatives in terms of knowledge transfer, and I will leave the floor to Timon so that he has enough time to talk. Thank you.
Thank you very much, Leonie. Timon, do you?
Yeah, so it's not letting me share my screen yet. Okay, there we go.
It's coming. I asked Timon to speak, to be the last one to speak, because I don't want to speak after him. You know, I had the experience at the university, and everybody is so interested in what he's saying that you know, as a presenter, you have no chance if you're scheduled to present right after him. So that's why he's the last one.
I'm flattered, Michelle. Thank you. So thanks for the lovely introduction. So my name's Timon. I am a person with lived experience of substance use. So I've been an injection drug user for about 12 years. I'm going to go pretty quickly through my slides because I wanted to cover a lot because it's a complicated topic and there's a lot I wanted to cover. So I'm going to go a little quickly just so I can cover it all. So yeah, I've been through various consequences of my drug use, from homelessness to criminal justice system and the likes. So that all kind of informs my experience through the system. So I've been through various aspects of the system, and so can kind of speak to what works and what doesn't. I'm going to start with a few examples of, I think, what works well in Quebec. So one of them, for instance, is with Metadam. So it's where I currently live. As Leonie was saying, Metadam is a by peers, for peers program for people with opioid use disorder. And it provides transitional and permanent housing. So I'm currently in the permanent housing. So that's basically a subsidized housing platform. And one of the really great things about them is that they, or at least one of the things I found great about them, was kind of the acceptance there and the lack of judgment. So for instance, they provide clean supplies in the day center downstairs. And one of the nice things was like being able to go down there and not, I don't know, like even if I was using it, even if I felt shit about it, they didn't judge me for it, or they didn't like, oh my God, what's going on? What's wrong? Like they just treated me as they did any other day. I found that really helpful. So yeah, and other things they did was like they helped me apply for the social solidarity benefits. They helped me resolve some of the criminal justice system stuff. So I'm going to come back to it a little later, but one of the things I think that we need a lot more of is kind of one-stop shops where everything is provided under one roof. And Metadam is starting with that. Next, one of the things I want to cover just briefly is adequate disability benefits. I think this is part of why Quebec maybe isn't experiencing quite the same levels of overdoses as British Columbia is, because as Francois was saying, the social safety net is a little bit more developed. So relative to its rather low cost of living, the disability benefits and stuff are quite generous. And that really helps as a safety net to prevent you from falling into homelessness, especially if you have a housing subsidy as well. Kind of prevents that deterioration of the context. Shouldn't have all these animations. One of the other things I wanted to talk about is Profan 2.0. So that's been one of the big pillars of kind of my stabilization, has been the job and the structure and routine it provides, but also the purpose it provides. Like I've worked for most of my adult life, and most of that has been in kitchens at McDonald's and stuff, which is really unfulfilling work and pretty slavish. So to actually be able to work in a field that I actually care quite a bit about and be able to do stuff has really helped me a lot. Move along to this part because I see I don't have a ton of time. So I'm going to get into now the parts that don't work so well in Quebec. So one of the first ones I noticed was, for instance, I don't think it's so much of an issue anymore, but certainly it was when I was starting to get treatment, was like this prerequisite that for you to get treatment for your mental illness, you first need to treat the addiction. You first need to be sober. You have like 6-9 months sobriety. Otherwise, we're not going to touch your mental illness. And I think that's a really awful approach. It really disregards people's chances, or lowers people's chances to recover. And it's also not particularly evidence-based from what I understand. So I think always treat both if you're in doubt. Another thing I noticed was, at some points I noticed it, is harm reduction messaging is really centered around like self-care and love and stuff, and that's marvelous, that's great, but it doesn't speak a lot to people who are, for instance, struggling with suicidality or risk-taking, which comes kind of with the territory of a lot of mental illnesses that co-occur with addiction, PTSD, depression, anxiety, all of those. So I think harm reduction still has a little ways to go in terms of developing messaging that caters towards those people as well, because those, if you think about it, are at the highest risk of overdose if they're not willing to interact with harm reduction services and the stuff that's meant to keep them safe. Another thing I think Quebec doesn't do super well at the moment is that kind of one-stop shop services. So I know in British Columbia, for instance, with the Portland Hotel Society and stuff, they have kind of safer supply under one roof with the housing, with social supports, everything is kind of bundled together. And from what I understand, Quebec still really doesn't have anything equivalent. And I think that's a kind of a big gap in the services right now is because if you don't have it all under one roof right now, what you need to do is you need to have basically a social worker or somebody to help you navigate it, because there's a lot of phone calls to make, there's a lot of people to coordinate with, you have to retell your story and your file like over and over and over, and so it's a pretty dehumanizing process and pretty discouraging as well. Like, it just makes the process of accessing care seem really daunting and unappealing. Last one is with the reintegration and empowerment process, I guess, is when you're coming out of active substance use, you kind of lose both of your communities because you're not quite a normie yet. You don't really fit in with the, for instance, I'm in a course at McGill right now for Francisation, and I have nothing in common with my classmates because they've just lived an entirely different life than I have. But concurrently, I've also lost my drug user community because I'm not using anymore. And so I'm not around them anymore. And I don't really have anything in common with them anymore either. And so I think it's kind of creating space for people who are in that in between. Another thing is kind of with the view of relapse. I think both societally and personally, certainly in my case, whenever I relapsed, there was a huge amount of shame and guilt, and that was really corrosive for me. And it just kind of perpetuated the relapse on and on and on. So I think if we can kind of change societal and people's views of relapse in that sense, that could go a long way to mitigating some of the harm of relapse. Areas for change and improvement. So I've kind of talked about it a little bit just in the last section, but my biggest hot take is that legalization is great, that it's the only way to comprehensively address the myriad of harms from prohibition. One of the things Leonie was talking about there was like the injectable opioid agonist treatment. So one of the things I think BC is doing really great right now is, for instance, one of the problems with the fentanyl crisis is that people's tolerance rises to such heights that the Dilaudid we currently prescribe as safer supply just doesn't really do anything. Like, I was on Dilaudid safer supply and it did absolutely nothing for me. So I think one of the things that we should import is, for instance, prescribing fentanyl to people who are dependent on fentanyl, because it's the only thing that's going to touch it. Another thing is empathy and compassion. So I was just talking about it a bit, but I think stigma is really corrosive, and too in the medical system, I've experienced it as well, and that can cause a myriad of harms, obviously. The last is that systemic coherence, or kind of increasing the availability, transferability, and dynamism of services, and that having more one-stop shops. Like, there's still a lot of wait lists for a lot of services, and there's still a lot of navigation you have to do of services as somebody trying to get treatment, and that's just unnecessary, I think. So I think I'm going to wrap it up there at 10 minutes exactly. Thank you, Michelle.
Thank you, Timon.